I have some questions here. I want to give each of you 3 to 5 minutes just to talk a little, just pick a story about your background, why you're doing what you're doing. And if you could, in that story, let us know like how cancer research and literature have impacted that, for the patients. How important has that been for you throughout your cancer experience? For Louise, does cancer research and literature, and does that come into play at all in your role? And so please describe your role too. And for the oncologist, obviously, and the researcher, so the media, we talked a little bit about media outlets and having more access to information and studies, and how does that play a role, or has it impacted your relationship with patients? So if you could use that in your story for the researcher. Is there a feedback loop? For example, as the researcher is out there and you see what's going on, how does that impact what you choose to do in your lab and your motivations? So if you want to start, Jen?
Sure, I'll start. Told a little bit about my story, but I'll try and talk quick since I know we're short on time. You guys all have very impressive titles here. I got to say, Leslie maybe at 65%, and I think I'm about at 30% understanding today. My title would be PCP, Professional Cancer Patient. I was diagnosed with breast cancer in 2007 at the age of 30, underwent a lumpectomy, 6 months of treatment, and then radiation, and 3 months later found out I had a recurrence and bone mets. Metastatic breast cancer at the age of 31. My son was almost 2. Statistically, I believe average life expectancy is 2.5 years, so my goal was to see him go to kindergarten, which will hopefully happen this fall. To answer Leslie's question though, and I alluded to this earlier, I spend days and days and days and hours making phone calls and looking for clinical trials that I may be eligible for. I'm in contact with NCI and looking what trials are available there. I'm in contact with a cancer center down in Texas and seeing what I'm eligible for. Luckily, we have Indy and Chicago and St. Louis all right here within arm's reach, and there are lots of opportunities there. When I was first diagnosed, I was eligible for a clinical trial. I did fall into one of the arms that would require daily shots to boost my white blood cell. But having a little one at home, I didn't want to have needles. It had nothing to do with my own fear of needles. I was too worried that my young one would get into them, so I did not do the clinical trial. And now I'm kicking myself for that. But looking at options, so I heavily do research on what's out there. Definitely watching Twitter and Facebook, and finding daily and checking all the websites to see what's coming, what's up and coming.
My name is Patience Sanders, and like Jen, I'm a member of the local YSC, and that's how we met. My story is that almost exactly 3 years ago this month, I was diagnosed with breast cancer at the age of 42. In my case, I was ER positive, PR positive, and HER2 negative. So that's considered one of the best diagnoses to get, and I consider myself very lucky. I have my treatment. I was stage 2, so they did find it in my sentinel lymph node, and that it was microscopic. They had to dig around for it, but they did find it, so that put me into an aggressive treatment protocol. And so I had the adriamycin, 4 treatments of that, followed by 12 treatments of Taxol, followed by radiation. It took about a year to get through all of that. I had a lumpectomy, and today I'm net. There's no evidence of disease. I feel like it's all behind me, and I'm reminded of it because I take tamoxifen every day. I'm 2 years into that, and I have my regular follow-ups with my oncologist, but I've gone on with my life, and there are some kind of residual effects. Sometimes I wonder, the chemo, I'm forgetful. I hear a lot about chemo brain. I don't know if there's anything to that or not, but otherwise I'm feeling pretty good, and I feel I was not part of the clinical trial because my facility that I was treated at didn't offer anything like that. So I would have been interested, I think, had I had the opportunity. But it apparently worked for me, so I'm not going to complain. Thank you.
Hi, my name is John McDonald, and I'm supposed to be representing cancer researchers. May not be a good choice because my story is a little bit unusual. I spent most of my academic life doing molecular evolution, and at the age of 56, I got contact. I was doing pretty well, publications in Nature, NAS and stuff. At the age of 56, I got contacted by a cancer surgeon in Atlanta who was specializing in ovarian cancer. And he had started an ovarian cancer institute. And he asked me if I would join him in doing the research arm of that. I had no background in cancer biology at that time. And it was one of those things in life where you say yes to something you don't know really why you said yes to it at the time. But it changed my life completely. So for the last 8 years, I've been devoted to cancer research. So even though I'm now 64, I've only been in this business for about 8 years. But I think one of the reasons I got into it was I kind of had the same feeling that Leslie had, that there may be opportunities for different perspectives on cancer research, new approaches. And I thought that with the years that I had left to work, it might be possible for me to bring some new perspectives into the area of cancer research. I think one of the things that has been good for us, and we started this surgeon started Ovarian Cancer Institute, which is a nonprofit organization. When we came into it, the only money that we had going was money that was donated from foundations or patients, grateful patients and things like that. So we actually, from the very beginning, spent a lot of time bringing patients into the lab. Part of it was really, to be honest, fundraising. But a good amount of our effort goes into translating the kind of work we're doing on a level that's understood by the patients. And we encourage the patients to come into our lab probably over about every month. We must have on average about 10 cancer patients, ovarian cancer patients, that come in to tour our lab. I think it's very good for the patients, for them to see what we're doing. It helps them to go out and advocate better for the importance of cancer research. I think it's also very good for our students to actually see cancer patients, that is, that they can connect the research they're doing in the lab to a real person, instead of just looking at it from the perspective of a test tube or working with animals. So that's a very important part of our research. I don't think that that's going on in most research labs, but it's really been effective for us. And I think it's something that researchers in general should spend more time doing, is translating what they're doing to the general public. Researchers complain about NIH funding being cut and so forth. I mean, part of the reason for that is because politically there's not enough pressure being put on the politicians to keep that going. The best way to do that is to advocate for the general public. They advocate for more, and they're going to be more inclined to do that if they understand what research is all about and how it's leading to progress. And so I think it's important for researchers to make that effort to communicate more with the general public.
I'm David Weinstock. I'm a physician scientist in Boston. And relatively early in medical school, I knew that I wanted to be an oncologist and a research-based oncologist. And that was really for 3 reasons. The first was that I wanted to do something that I thought was important. And there's nothing wrong with being a cosmetic dermatologist or something like that, but it wasn't the job that I wanted to go home from every night. I wanted to feel like I was really contributing something meaningful. And I consider it a tremendous privilege to work with patients while they're going through these unbelievably trying but important moments in their lives, and to be able to share that with them and to be able to provide support and guidance and also learn from them is a tremendous privilege. The second reason was that oncology, as many of you I think are recognizing, has a tremendous opportunity to interface between the laboratory and the clinic, and there may be no other field where advances can come so rapidly. So on the forefront of cancer genetics, where I sit, we see something new literally every day, and sometimes paradigmatic, something completely changing the way that we think about cancer biology. And so then I think the third reason was that because of this very rapid advance, I recognized relatively early on, and I think many people also feel this way, that over the course of my career, certainly, we're going to see tremendous advances in the treatment of cancer. We're going to see better outcomes, we're going to see less toxicity, we're going to see more survival, and we're going to see more and more people living with and being cured of cancer than what we could have imagined a decade ago. Now, I think that offers very little solace in a way to people who are living with cancer right now, and they need a cure today. And there's no right answer to that. You can rationalize that these are scourges of humanity, that every human being, since there were human beings, has suffered from the risk of developing cancer, and it's incredible the advances that we have made. But again, it offers very little solace to someone who needs cure now for themselves or for a loved family member or for a friend. So when I put all that together, I think the earlier discussion, maybe we can get back to this later, about participation in clinical trials, it's actually emotionally hard for me to think about it. I mean, I would say, based on the vibe in this room, there are probably a lot of people here who idolize Steve Jobs. And if you look at Steve Jobs, his personal experience with cancer, he was diagnosed with pancreatic cancer, a neuroendocrine type of pancreatic cancer that was curable. And for 9 months, he took juices and did acupuncture and refused to have surgery. And by the time that he ultimately accepted surgery, his disease was metastatic. Now, it's certainly possible that it might have been micrometastatic before then, but I think there's reason to believe that he's not alive today because of the decisions he made. Here's a person whose entire life was dedicated to technology. And for whatever reason, he was unable to either believe enough in or somehow give himself up to the medical system and have surgery when he could have had it in the first place. And if we can't convince Steve Jobs to participate within the medical system, we obviously have a lot of work to do.
I'm Louise Spellman. I work at Provena. I'm a patient navigator, so I'm a totally different aspect here. I've been in the medical imaging field for 35 years and had the opportunity, a new program at Provena for patient navigation. I jumped on that opportunity. My mother died of ovarian cancer at a young age, and I saw the need and the support that these patients need that you all don't see. And the example, like I had a patient that just had a diagnosis. She called me every day crying and not knowing what to do. Should I do it? Should I not? And I went through her path reports and explained how early it was, and because of all the research, the advancements in early breast cancer is so great that she did have the surgery last week, and she still calls me about every other day, talking about her experience and about how the support, having someone there to connect with, to at least listen to these patients. They're out there and they're lost sometimes. They need someone to talk to, just someone to listen to them, give them ideas. I am not that involved on the oncology side and with clinical trials. I can see now I need to be a little bit more connected for these patients to at least be able to know where to guide them. So it's a learning process for me, and I feel like I can help a lot of people out there if they ask for it, or I can go reach out to others to help them. So just from my background in medical imaging and being a person that wants to help others, that was my whole goal, why I chose to go into medicine 35 years ago.
Excellent. We have about 20 minutes for the panel, so I really want to encourage any questions from you guys. I know you've had to sit and listen for a long time, and now is your chance to ask those burning questions that you want to hear. You can ask, I'm sure that Jen and Patience will tell you every little detail about what it's like to go through treatment if you want to hear that. I'm sure we could ask about well, you don't need to ask about the details in the labs, but maybe somebody else, maybe one of us normal people here would like to do that. So can we take a moment and just see if there are any questions?
Hi, I have a question for Jennifer. So I'm 27, right? So I'm not that much younger. And when I go to the doctors, and I ask about, should I start worrying about things like cancer, and they're like, oh, you're too young. And so I guess my question is to you, how did you realize that you had cancer? Or, how did it all start?
Don't believe you're too young. I had a baby and was nursing my baby who was 8 months old and happened to notice I had a lump and thought it was a clogged milk duct. And thankfully, I was not told you're too young. At his 9-month-old pediatrician visit, I said, I know you treat kids, but I found a lump. And thank God that pediatrician said, get it checked out, just for your reassurance. I'm sure you're fine. You're healthy, you're young. I joke, I'm like, I don't even have cavities. How can I have cancer? Relatively healthy. But I got it checked out, went and saw a nurse practitioner. She said, I'm sure it's nothing, but let's do an ultrasound just in case. And then a friend's husband, who's a radiologist, said, the scan looks kind of fishy. Let's do a biopsy to be safe. And sure enough, it was breast cancer. I did, speaking about stages, had a lumpectomy, had clean margins, had no lymph node involvement. We thought, great, we got it all out. Was stage 2 from the beginning, did all the treatment, and so then the cruel irony that it came back. Once we did get it stable for a little while, had another lumpectomy, did not get clean margins, had another recurrence. Just in December, we couldn't get the breast tumor under control, the bone seemed relatively stable, so had a bilateral mastectomy without reconstruction, and decided if I am living this life, which statistically I should not be alive, but I'm not a statistic, I'm a mom and a friend and a daughter, but if I'm living this life, I'm not spending it, no offense to you guys, in more doctor's appointments, so I did not want reconstruction. And then lo and behold, it pops up in a lymph node and in the skin. So it seems like I'm this freak of nature. Whenever we cut it out, it comes right back. But I would say absolutely don't believe that you're too young for this. The youngest I know personally was diagnosed at 19. I had another friend diagnosed at 20 and died at 23. So yes, we're statistically, we're completely off the charts in terms of average age of diagnosis. I believe is 60, 61. But we're out there and we're trying to be more active and be heard, because as Leslie showed in that graph, oh my goodness, childhood cancers and adult cancers we're making great strides on, but the young adult population is being left behind, and really looking as researchers, why is that? And trying to find those answers and make advances there.
So I'm going to ask a very, I think, potentially charged question. But I'd really be interested in your thoughts, and I wouldn't do it otherwise. There's obviously, in the last couple of years, there have been government committees that have suggested that we come backward in terms of extensive screening for different, both PSA and mammogram. And you're in a room of scientists, but also children's brothers, sisters, friends, mothers, and so on. And we all have personal feelings, and we're all also trying to move the science forward so that we can help as many people as possible. And so how do you reconcile that, in your mind, about whether maybe sometimes it's right to be doing less rather than more, and maybe sometimes the government might say one thing, but that I just can't go along with that.
My personal standpoint, and I'll take Leslie's, just me, I think it's so important to know your own body. Mammography failed me all 3 times, came back clean, but luckily breast MRI showed up, and the biopsy showed up. I think it's so important to know what's normal for your body, notice when it changes. And as young adults, often we're so preconceived with what we look like, an outward appearance, and it's so important for us to notice those internal changes that only we would know on our bodies. So I'm really excited to see some of the poster sessions and looking at what could be coming in the future in terms of diagnosing earlier or not using mammography as an option for finding tumors. But I think right now it's really, it's a personal decision, but you only have one body. You got to know what it is and how to treat it and take care of it.
I just came back from the conference in Vegas on the breast conference, and there are other alternatives. There's full field ultrasound scans that they do, but insurance doesn't cover it. And so some people aren't able, I'm sure if they can, they would, are not able to pay for that. And so these things, we got to get that through so that they can have that to offer the patients. There's tomosynthesis for mammography, which is like a tomo unit that goes through and takes a slice through the breast. And these are also, especially for the young women, because their breasts are dense. And that's why mammography a lot of times fails, because you cannot see that on mammography. So I'm a mammographer also.
I'll just say, in my case, I think I started routine mammographies at 40. And then I might have had one or two that were negative. I found mine myself. It wasn't even a self-exam. I think I just, kind of rubbed, and there it was, just right on top, could feel it. I don't know why I hadn't noticed it before. It was like a pea right under my skin. So I guess the routine mammography it didn't work for me. In fact, a lot of people, this is just anecdotal. But most of the women I know, it wasn't found through routine mammography. I don't like the idea of scaling back, but in my experience, most of the women, and it's just me, didn't find it through routine mammography. Well, and the women I know are younger. I mean, in my peer group, but I still don't like the idea of scaling back. When I first heard that, it seemed a little wrong to me. So.
I would agree, because my lump also, I had my first mammogram when I was 34. Because when I was getting my routine exam done, the nurse practitioner was doing the breast exam, and she's like, "So are your breasts normally lumpy?" I seriously know your body, right? I'm like, yeah, I guess so. I wouldn't call it smooth, and I didn't know how to answer. And she's like, "Well, I'm going to send you down for a mammogram anyway, because my mom was a breast cancer survivor, so insurance wouldn't matter that I was under 35, blah blah blah." So I had the mammogram. It was fine, and I never thought about it again until I was 36, and I found a 4-centimeter lump in that area that she had felt when I was 34. And at that time, nobody thought to do an ultrasound or a follow-up, or it was just, I was there, and then I wasn't there, and then I was going through chemotherapy. That's what it felt like. So yeah, mammography let me down too, I think, in a long way. So I think we can't become complacent with the technologies. This is the best we have right now, but it's not good enough. And that's why I'm excited when I hear of the developments that are happening on this campus, with the imaging research that's going on, because all of my hopes for every future woman are, is in that research. And I often call cancer researchers my heroes, because they are going to save a lot of people. So, any other questions? Yeah.
I want to ask the cancer researchers. I read an article recently that said that there was a hesitancy on the part of drug companies to test multiple drugs at one time that seemed like they might be more effective, because if you find anything wrong with or any side effects with one, then the whole thing is blown. Is there still this tendency to just do one drug at a time, or is that, it seems like it could be more effective if you could have two targets rather than one?
I think that paradigm is changing. I think they're more willing to go with multiple drugs at one time, but it certainly was true for a number of years that they preferred to do only one.
It's still problematic at the FDA to get approval of a combination of therapies where neither one of the two therapies is already FDA approved. So if you're trying to add a drug onto an FDA approved drug, but there's a huge move within the cancer research community to try to figure this out. And in fact, many people, so Bill Sellers, who's the head of Novartis Cancer Research, who I think is the smartest guy I know, has said that the company that figures out combinations is the company that's going to win, basically, this race to find the best cures. And there's a company called Combinatorics that all they do is combinations. So they take 1,000 different kinds of cancer cell lines representing every major kind of cancer you can imagine, and they take 300 compounds and they do every combination. So you can imagine 300 times 300 times 1,000. You're talking about 90 million different combinations and very high throughput to try to figure out what are the right combinations of drugs that we should be pursuing, both to get those into the clinic and also to try to investigate what's the biology underlying responses from combinations that you wouldn't necessarily predict. So the short answer to your question is, I think it's moving in the right direction, it's still got a long way to go.
And I think from the molecular biology side, from a researcher's perspective, we know that the correct way to go is multiple drugs, going for multiple targets at the same time. So I think that's the reality of it. It's a question of getting that information translated into through the system where it actually is being implemented.
To kind of dovetail on that, for future researchers, the one thing I would ask from a patient's perspective is to really look at the quality of life and how you're impacting that patient. There was a lot of excitement over Vivulin or Haviland this last year for breast cancer. About a year ago, was released an extended life on average 3 months. So I tried it last summer. I had such severe neuropathy, I couldn't twist the bottle cap off a bottle of water. My son, who was 4 at the time, you couldn't tell my handwriting from his because I couldn't hold a pen. I had difficulty walking upstairs because I had significant atrophy in my muscles, and it didn't work. And even if it had worked, my quality of life was so diminished that I would have stopped anyway. So I think there are some really awesome things that are breaking and groundbreaking that are coming out right now. But I hope you keep that in the back of your mind, that looking how this, how things impact cells, that's great. But how does it really impact the person and their life and the lives of their loved ones and how they're able to maintain that quality of life, especially when their quantity of life is really uncertain.
I mean, as far as we've advanced, for the most common epithelial tumors of breast, cancer, prostate, pancreas, ovarian, we don't even have a paradigm for curing people who have metastatic disease. There's no single or combination therapy that to any extent can be called curative once the disease has spread. So I think what many of us believe is that it's going to take additional paradigms, and that's going to include many of the types of approaches we've heard about today, including targeted genetic therapies and siRNA. We haven't even discussed immune therapies, and then traditional chemotherapies, and then targeted therapies against driver oncogenes and other alterations that we know are making that cancer behave like a cancer rather than a normal cell. So how we're going to put all those therapies together into a curative cocktail when so many of them are currently not available is really a daunting challenge. But I do believe that that's where the interest is in the cancer community. And we've moved beyond the point where we think we're just going to find a magic bullet and that one compound or siRNA or immune therapy is going to be the answer for a significant number of people.
Yeah, I think as a researcher, for all of the reasons you said, that we think that early diagnosis is key to get the disease diagnosed before it metastasizes, because that's when it can be most effectively treated even with existing therapies. So I think there's a lot of breakthroughs being made in the area of diagnostics that I think is really going to impact the future.
Are there ways that patients can be, help progress those agendas? Do you think, from your perspectives,
it still comes back to educating the public, and it's contingent upon researchers like myself to facilitate people like you who are willing to get out there and shake the community up to see that you have the information you need to go out and to move things forward in the general public. I mean, we can always say we need more money and things like that. I think also as researchers, and probably, I don't know if you want to comment on this, but there's some issues about how the money is being spent. And I mean, I just came from the AAAS meeting. There's something in the neighborhood of 20,000 people at this meeting. I assume every one of them is being funded in one way or another. And I had to keep asking myself the question, how can it possibly be that this number of people are being funded with this amount of money for the last 50 years and we're still, not further along? I've got to believe that some of the money is not being used in the most effective way. I don't know exactly how to deal with that issue. I don't know, maybe anybody else.
I certainly do not have an answer. I'd like to think to a certain extent, these are really hard problems. Really, really hard problems. There are clearly larger design issues of cancer research that many smart people are thinking about. I mean, if you think about research, it's pointillism. So it's that form of art where you create a picture by making a million different points on the canvas, and that somehow creates a picture. And so it's even more complex than that, because I may be funded to make a certain point, but halfway through the research I realize that's actually not what's interesting. What's really interesting and driving my research is somewhere actually over here. And somehow we're all working together and independently and collaboratively and competitively, and we're trying to create a meaningful picture of what the biology is, and then link that to chemistry and immunology and everything else that moves us to new treatments. I've actually forgotten what the original question was.
The patient, well, you've done a fantastic job. We can actually ask, see if there are any. We have, 4 minutes left?
I can actually go.
We could go. Oh, okay. Got extra time?
Hi. Sorry for so many questions. So I actually have a question about clinical trials, and I kind of wonder, hearing what Jennifer was saying about how hard it is to get into one. If you're really desperate, why can't clinical trials be open access? Where if you're really desperate and you kind of know, well, I may die, but there's some hope, and I have this metastatic cancer, that you can go online somewhere and it has all the different clinical trials that are compiled, and you can just basically enlist yourself in one, and you can be anybody, right? Is that feasible? I guess is what are.
I think that's a wonderful question. It reminds me of what the original previous question was, which is what can we do? The answer is email your Congress people and senators and do it over and over again. I'm totally confused by why some people are so into cancer research and other people just do not care, because it affects all of us. No one doesn't know someone who had cancer or has cancer or died from cancer. It's a very strange sense of dissociation from cancer that I'm sure psychologists could work on for their career, where people, if you hear about a bone marrow drive for a kid who has leukemia and so on, people will come out of the woodwork and donate their blood and so on. But we have many, many patients with cancer who refuse to donate their tissue or their blood as part of the process of their diagnosis, just for a researcher like me to work on. And I don't know why. There's a certain lack of trust.
Well, part of that is legislation, because before the GINA Act was around, the genetic information, whatever that's for protecting our information, if our insurance companies heard that we are, BRCA1 positive or something, then they could deny us coverage. But that doesn't exist. So policies have helped make it a little bit, at least, easier. Sorry.
Back to your question. The main answer is this is research. So this is no different than you doing a controlled experiment in a way. And it's very difficult to relate that to human beings who want to participate in these trials. But you have to decide what's going to be in your experiment, and you have to follow what you said you were going to do. And that's the only way you're going to be able to interpret your data. And 364 days instead of 365 days, that is stupid.
Yeah.
But that's the way the trial was written. And if we start bending, even when we should, then what does that say about the quality of the research that we're going to be producing?
My non-scientific perspective, I think a lot of it also from a pharma company, It's money motivated. I am a real big risk to them. And so if I was enrolled in a clinical trial, since I'm so heavily pretreated, and their drug didn't work, that brings their success rate down. And so I think that's another reason why they make the gap so narrow in order to get into their trials, which I can understand when I'm able to personally remove myself from it, but it's hard to understand on a personal level.
This question may be confusing, so bear with me. But I wanted to go back to your earlier point about the pointillism and how that works with regard to research. We hear about incredible research on the diagnosis side. You know, we're looking at cancer as a whole, here's the different ways we can tell it's there. Looking at cancer as a whole, here's different ways we can target the treatment and get it there. But I wonder if there's any value in sort of taking some time not focusing on the big picture and actually getting down into the very narrow. I mean, we have huge cancer communities, huge conferences where everyone's focused on cancer. Is there value in sort of breaking those communities down and having a community that's focused on just, you know, this specific part of the pathway? What I'm trying to say is there value in changing the approach to cancer research?
Well, I think cancer research is a hydra. I mean, there are meetings all the time on the most, minutia, the tiniest aspects of cancer biology, where the people in that field go there and talk about, their particular details. And then there are these much larger, 30,000 foot view type of meetings. There are policy meetings there. So part of having 20,000 people working on cancer is that you kind of get everything, but it's a bit unorganized.
Great. Yeah, I agree. I mean, there are detailed there are meetings that on specific pathways that go on. The problem with cancer is as you said before, it's very complicated because we're dealing with cells that are highly integrated, and it's not like you can hit one thing and not affect something else. And the cancer cells, my background being in evolution, these cells want to survive like all living things want to survive. And you can hit them at any one given point, but they're so robust and so integrated that they're going to look for alternative ways to get by whatever you throw at them. And so I think that the way we have to approach cancer is from a holistic, looking at it as an integrated system, and how best do we treat integrated systems as opposed to diseases like sickle cell anemia or something that's affected by one single gene. We know how to deal with those kind of diseases. But we're not used to dealing with diseases that are really system-wide and highly integrated. And that's what's making it so complicated and so difficult to figure out how to deal with it.
Hi, so this is for the cancer researchers, as well as anyone else who might have any experience with this, but how do you, so for the researchers in particular, how do you engage members of your research group? How do you get your students to be involved and to go out and actually, interact with patients to really drive some of these points home? Or is that a part of what you try and instill in your students?
Yeah, well, in our particular case, we're bringing patients in all the time, so the students are continually interacting with the patients. I don't think that that's typical, but in our case, I think it's very effective. I think it's highly motivational for the students, as I said before, to have patients come through to see what they're doing really has an impact on human beings. And I think it helps motivate them, helps them to work longer hours or to get really behind or get more out of them for the low pay that we give them.
I thought that was beer and pizza that did that.
There's a big gap between curing cancer and what a student or postdoc needs to think about and accomplish to be successful. A postdoc or a grad student needs publications and notoriety and advances and so on. And even if they're working in cancer, it doesn't mean they always need to be focused on trying to cure cancer. And that's actually a problem, because too often they're thinking about the competition or how fast I can get this out or all the other nitty-gritty of being a scientist that don't really have to do with anything. So I think we try to reinforce in my lab and in our division that we're there to help patients, and everything we think about should be thought in that paradigm. Many of the people in my lab are funded by agencies like the American Cancer Society or Susan Komen or the Leukemia and Lymphoma Society, and those organizations have events where these graduate students and postdocs can participate and they can meet a lot of students. Where my lab actually is used to be in the same building as where the clinics were, and so the people in my lab would ride the elevators with the patients. But unfortunately for us, not for the patients, we built a brand new building that's purely clinical, and they've all moved out. And so now the grad students and the postdocs really don't see the patients the same way, and that there's a loss there.
Right. I think the kind of pressures you're talking about are also felt by the PIs. You have to publish to get tenure, you have to get grants. And unfortunately, that can lead to a situation where a paradigm develops that I'm doing science to get money rather than I'm getting money to do science. It puts the emphasis in the wrong place. And I'm just saying this because I've come into science, cancer biology late, but it appears to me that because it's very expensive to do this, that in some cases I see units developing that are constantly thinking about what grant can I get out? Here's a grant, I can get some money. And the motivation is to get the money, and I keep saying to myself and to them sometimes, really the goal of this is to get somewhere scientifically. It's not, we should think about, is the experiment really worth doing to advance us scientifically, rather than thinking, let's do this because there's a grant out there that's in this particular area. But that's a problem that I think that the whole community faces, and I think we have, because we're pressured to get money and to produce, sometimes it's easy to forget why we're there in the first place. We're not there to make money. We're there to try to advance the research of cancer to help patients ultimately.
I think that's probably, how long do we go?
3 more minutes.
3 more minutes? I thought that was a great statement, so I was going to cheer it on. But any other questions? One last question. Yeah. She's coming.
I just make this comment to maybe inspire our students here. When you said there's 20,000 people in this room, and after that you were at this conference, and after all this time there's still no cure, that maybe the answer isn't 100% in medicine. I believe that cancer is a systemic problem that requires systemic changes, and maybe some of the research has to be done to pair up nutritional changes and exercise and all that along with medicine. And being a stage 4 breast cancer survivor that went from stage 4 to remission in 9 months and made those changes, and I'm here to talk about it, I just felt compelled to make that statement, to maybe try and partner those ideas into research together.
I agree completely with that.
Okay.
One more question, I guess. They're looking, the guys with the microphones are ready to run to you. Yeah.
Since no one brought this up, let me bring this up. This is food for thought. So if you go to New York City and sort of stand outside the subway close to Wall Street at about 2 o'clock in the morning, you'll see a lot of people wearing ties like I am today for an entirely different reason. But coming back from work. And if you stood there for a few more hours, at about 6:37, you'll see them coming back to work. These are investment bankers. And they work really, really long hours with great dedication to make a little bit of money. I have not seen a single grad student ever in my entire career who goes home at 2 in the morning and comes back at 7 in the morning, unless there's something due the very next day. So I think we, perhaps as a society, have placed maybe money ahead of cancer cure, for example, among other things. And I have no idea how to change this. To those in my research group, I'm not advocating, and I'm not going to expect you from tomorrow to come in at 7 and but at least there should be 4 or 5 such people, and quite unfortunately, there aren't to that extent. So I
the
like
same people.
The same people?
That go in, come out on those, at those hours.
Yes. So I have friends who've done that. They work 20-hour days and, burn out after 4 or 5 years. But, until in tenure track, you might still see a few people working 20-hour days, but it's not sustainable and it's not a culture in cancer research. I don't know how to change that. There are very many dedicated people, but perhaps we're not quite as glamorous as Wall Street.
I completely agree with you. In fact, before the recession and the Wall Street collapse, over 50% of Harvard undergraduates were going into finance. And I was in leadership at Harvard College, which I will never be. I would find that shameful, absolutely shameful. And yet that was the state of affairs, and it says a lot about not just what our society is, what our culture is, and so on, but about how we, or our field, I shouldn't say we, because I don't know that it's within our power, but our field is not attracting a lot of people who could make a really big difference. It's not necessarily that we're not motivating the people we've got. There's a lot of other really talented people out there, and they're not choosing to be cancer researchers. And so thinking more about how we could make a really big difference.
Great. Thank you. I think that is the final wrap. What's coming next? Is it a break now?
Yes, great.
Break? There are cookies out? No, I don't know what they're about.
At 4:45.
Reconvene at 4:45? All right. Thank you very much, panelists.